All right, hello everybody. Welcome to the next session of Virtual Global Spine. I am honored and very pleased to introduce my very good friend and colleague and mentor, Dr. Arthur Jenkins. He is the director of the Spine Institute for the Institutes of Specialized Surgery. He's the CEO of Jenkins Neurospine, and he was a very, very close mentor of mine throughout my residency and fellowship, and even in my career now. So it's always great to introduce him. He's going to be talking about the MUST-D procedure, one that I'm very familiar with through my residency at Sinai. And at this point, I'll let you take it from here.
Thanks a lot, John. It's always an honor to be able to present and work with you. You truly epitomize what a class act looks like. So, everything you do. So happy to be here and to, you know, share what we've been working on. And you've certainly seen what we've been working on, so you know that it's a worthwhile endeavor. So I imagine that for many of you in the audience, you've treated spine tumors or seen spine tumors at some point, and they are certainly both it's a great treatment group because we can do so much for them, but it's also frustrating dealing with some of their complexities. And so about 20 years ago, I really did a very deep think on what we were doing and how we were doing it to get to this procedure. And so I'm going to tell you a little bit about how we got here and where we're going from here. So before we get started, let me give you my disclosures. I have no material conflicts of interest with what we're talking about. I will say that I am a minority investor in two companies that are related to biotech, but not related to the surgery for spinal tumors. I am the owner of my own company that does develop some patents that I have been developing. And in that particular regards, I do have a patent jointly held with Mount Sinai. But it's not going to be discussed in this endeavor. However, I am open to other conflicts of interest. So if anybody wants to discuss any of these things, more than happy to entertain that with you afterwards. Before we get started, I would like to take a moment in memory, silent memory of my co-resident, colleague, fellow spine surgeon, and fellow academic spine guru, Dr. Michael Groff, who passed away last month in a tragic accident when he was traveling with his family for a holiday get-together. And the spine community has lost a dear friend and collaborator and really just a truly great father and man. So just if we could take a moment. Mike will be missed, and I'm sure he would have liked to have been here. And I'm sure he'd have a few choice thoughts for what we're doing. So standard open tumor surgery, consists of multiple different approaches depending upon the location of the lesion. We've got our direct posterior, we've got posterolaterals, we've got our anterior approaches. And in fact, in the 90s and 2000s, it was all the rage to be doing en-bloc spondylectomies. Take the whole darn tumor out, take out the entire vertebral body. I mean, bigger is better. And that was definitely the rage of the 90s and the aughts. But the problem was, especially in most people's hands, these were very sick patients, very high complication rates, and a very high recurrence rate. Many of the articles that quote recurrence rates in spondylectomy don't even quote them out long enough to be meaningful. In addition to the surgical approaches, we have adjuvant therapies that we may want to employ to help manage the tumor itself, because these are metastatic lesions. The vast majority of spinal tumors are metastatic. So there's a primary somewhere, and there are other mets out there. It's almost impossible for you to have a solitary met that goes to the spine and not have lesions elsewhere. So we do need adjuvant therapy. Immunotherapy has actually been a big boon lately, and we're seeing a lot of advances in that. But standard chemotherapy and radiation therapy are the mainstay of how most of these have been treated for decades. Now, the first question you have is, when we're doing spine tumor surgery, why do we need to do such a big operation? And the answer is it's partly because the tumor has destroyed some of the vertebral body or the vertebral elements. But the reality is, and this was an epiphany I had about 20 years ago, the vast majority of what we're doing as spine surgeons for spine tumor cases is not because of the tumor, but because of the approach we take to get to the tumor, which is in the middle of the vertebral body. And we take out so much to get to it that we leave it unstable, and we need to therefore provide additional stability, which is then a much bigger construct. So in the pursuit of doing this, we then wind up having to do all of this. So you begin realizing maybe we're overdoing this. And it was when I had a discussion with one of my radiation oncology colleagues that really made me think long and hard about this. These are big surgeries, sick patients, very high complication rates. Potential recurrence. I mean, most of these patients do get recurrence unless the medical treatment gets it under control. And then the image quality afterwards is abysmal. Most people don't even bother with postoperative imaging to see if they've got a recurrence because you can't interpret with that much metal in place. So why don't we think about that differently? In addition to that, when we're doing big spine surgeries, especially fusions, our adjuvant therapies may be working against us. So for most spine surgeons who do spine tumors regularly, they're holding off on the adjuvant therapy for weeks, sometimes even months after the index surgery, which unfortunately gives the tumor a chance to grow some more. So it's the different treatments we're doing really do work against each other in many of the cases. So what if we could get the tumor out without destabilizing the spine, reconstruct the spine that has been damaged and to maintain stability, reduce the impact of the surgery on post-op recovery? I mean, we've all had patients who it's the complications that really did them in more than the cancer itself, and reduce the impact of the reconstruction on their post-op imaging. Is that something you might be interested in? So what if instead of doing the top, what if we just did the bottom? And that's exactly what we did. So this article just came out. This has been a 20-year labor of love to get this done and get it right in the Journal of Spine Surgery. And I want to thank my co-collaborators who I've been working with, some of whom I've been working with for, 5 years or more. And so this is something that's been, we finally were able to bring it to fruition. And it's a pretty simple concept. Stick down a Metrix tube, park it next to the spine, take out the tumor, put some cement in, and get out of Dodge. Don't poke the bear. Sneak in and steal the bear's honey without waking up the bear. So let's start with the basics. We have our vertebral body, and then we have the vertebral body tumor that's eroded a significant amount of the vertebral body itself. We have the epidural extension of the tumor, and then we have the spinal cord sitting in the spinal canal. And the anatomy that we're going to be working around are the ribs, the costovertebral junction with the rib, the costotransverse junction with the rib, and the transverse processes. So we know how to do costotransversectomies, especially open. They're a lot easier open, but we can do them minimally invasively. In fact, that's how I do most of my thoracic discs. And so it's a pretty easy transition from one to the other. So let's do this. We just take your Metrix tube down. You find the costotransverse junction and then follow that along the top edge of the rib to the costovertebral junction. And then once you get the Metrix tube or whatever dilator tube you want to use, you get it down into place. you encounter the tumor and then resect the tumor that's in the epidural and the intervertebral space. Then, and I do this most of the time, but you don't always have to do it. You pack you put a small screw. I take the screws out of a cervical plate set and use 14 to 16 millimeter screws. And I just put it partway into the bone, but so that the head doesn't stick out of the bone. And the idea here is I'm just creating a little anchor. It's not a big pedicle screw construct. It's just one tiny little titanium screw that's just as an anchor for packing cement down into the hole around that screw, but using instruments to push it away from the spinal canal itself, essentially packing it in and contouring it to where the vertebral body used to be. So now we've filled this up. Now let me show you what that looks like in real life. So we start with this case, and essentially it just goes like this. It's super easy, goes very fast. See, I mean, you guys are operating at this speed all the time. And you just clean up the area. That's a little bit of Surgifoam and some gel foam. And then we then go to the resection component where we are parked at the costovertebral junction. And we start taking the tumor out in the space next to the root, between the root and the thecal sac. And we're just reaching under and around, removing the soft tissue tumor until we start creating a cavity. And once we get all of the soft tumor out, sometimes we make a little more room to get more access. Sometimes we'll clip the root at the exit from the dura just to allow us to manipulate the cord a little bit more if we have to reach across to get more tumor. But that's a pretty straightforward thing to do in the thoracic spine. And in the lumbar spine, there's a lot more manipulation able because there's not a cord on the other side of the dura. So then, as promised, we put a screw in and just screw it down tight enough that it's past the thecal sac, it's in the cavity of the resection, and you just leave it there. And then we start dropping little pieces of pre-mixed polymethyl methacrylate. And I found it's a lot easier to get it right by taking some of the material and waiting for it to get just a little bit more than liquid, balling it up and putting it down the tube, and then packing it down with the right angle instrument. I think that's easier than trying to squirt it in because inevitably it's either too runny and it gets sucked up your sucker while you're waiting for it to cure, or it's just not going where you want it to go. So this way I can keep it where I want it to go. And then we just fill the space so that it looks like this when we're done. And in the end, that's what it looks like. You would get x-rays intraoperatively to make sure you've put it. I would typically do an ISO-C 3D reconstruction to make sure that I'm happy with how it looks and that it looks similar to this. But the idea is as long as there's no cement posterior to the posterior canal and there's no cement extravasated anywhere else, you're done. And you can take something that looks like this and turn it into something that looks like this. It's a very effective technique for getting the tumor out. And it actually works really well without resulting in significant instability because you didn't take away the inherent stability of the rest of the spine. So in our series, we had 21 patients that we had done this particular procedure on. We had done a lot of other MIS tumors because they are different. If you just have to do a lami or a laminotomy to get the tumor out, it's a different animal. This is just focusing on vertebrectomy for intravertebral with epidural extension. These all had to have epidural extension or they weren't part of the series. But no significant difference in any of the demographics there. Both groups were identical between getting standard open and the must-D procedure. And there was really no significant difference in the tumor biology between the two groups. These were just the various patients who were referred to either myself or one of the other surgeons at Mount Sinai at the time, where all of these were performed. And there's a pretty similar distribution as you'd expect. The vast majority of patients were thoracic, but we had our lumbar and we had our occasional cervical. There was no significant difference in their SIN scores, so that from a biological and from a biomechanical point of view, they were pretty similar, as were their focal Cobb angles pre-op. And so what we're looking for is, did we somehow stratify these patients inappropriately? And they're really truly no difference between the two groups. But once we got started, that's where the differences really picked up. So when you look at the skin-to-skin time, it's almost 2 hours shorter to do the must-D procedure. That then turns into, once again, almost 2 hours difference in the wheels in, wheels out, as well as not surprising, if you're doing an incision this big versus an incision this big, a much lower blood loss. And in fact, actually, the blood loss we had in our first 5 patients was the highest of all of our patients, because after the first 5 patients, we embolized all the patients pre-op, and that dropped off to more like 200 cc's. But we included all of them in this series, because even with that, the difference between the control and the must-D patients was still pretty profound. I think if we'd had one more patient in our group, we would have had a 0.05, but it certainly is a very significant difference in the blood loss. And you can see that the p-values on the duration of time these sick patients are under anesthesia, pretty significant. So we look at the post-op statistics. Well, how'd they do? That's great, but how'd they do? And the answer is they did great. They actually, many of them went straight home instead of even going to rehab. The length of stay was less than 5 days for our series, and almost 10 days for the standard. And one of the big things is that some of these 5-day length of stay was because they started chemotherapy immediately post-op. So they got transferred to the medical service, but that was considered a delayed discharge. So we had to eat the chemotherapy part of to stay. So and even with that, you can see the p-value is pretty strong. And they were up almost immediately. The recovery was nothing compared to a standard open tumor, where the average patient didn't get out of bed till 3.5 days after surgery, whereas the vast majority were out of bed by the end of post-op day 1. And so our 30-day change in their ability to ambulate, we used a score called the Hauser Ambulation Index, which is validated in MS patients, but it really stratifies very nicely whether you're a freely ambulator who's got no restrictions and somebody who's bedbound with a 0 to 9 scale. And we saw that there was a very strong, significantly better ability to ambulate after the must-D procedures. And that's at 30 days. We didn't just say, well, post-op day 1, they couldn't. We really looked at 30 days when they should have been recovered from either procedure, to see how they were walking. And I'll show you that in a sec. We allowed them to start radiation therapy earlier, but in many cases they just didn't. But we still started their therapy 2 weeks earlier with the must-D, because you have a tiny incision, and because it's a paramedian incision, it's out of the primary radiation field. There's really, I told them they could radiate post-op day 1 if they wanted. And this last line speaks to the heart of why we do this. We had no complications in this group. None. No infections, no DVTs, no PEs, no pneumonias, none. I mean, I know that sounds hard to believe, but I think, if anybody wants to check on those numbers, I'm certainly happy to go through it with you. But once you've done this a couple of times, you realize, why am I even doing it the other way? And I did. At that point, about halfway into this procedure, I pretty much stopped doing standard open procedures for anyone with 1 or 2 levels of tumor involvement. that included vertebral body with epidural extension. So it's a pretty impressive degree of improvement. And it just, once you start, you almost can't stop. So when we look at the ambulation scale here, the 30-day, so they started and there was no difference between our starting groups. And so 9 is a terrible score. 0 is perfectly intact. So we saw that these patients actually improved from our treatment MUST-D group. And if anything, the control patients were slightly worse at 30 days post-op. It was almost none got better. And this was a scatter plot of each of the individual patients looking at, and then we also scaled it because what we also found was that those who walked well pre-op, most of them walked well post-op if they were tumor or not tumor. But if you didn't walk well pre-op, you actually did much better with getting the MUST-D procedure. Whereas if you weren't walking well pre-op and you got a standard spine tumor operation, you did worse. You just did worse, and that's this group right here. You can see they just did terribly. Sorry, this group right here. So what we were looking at is the poor ambulators in the MUST-D got better, and the not so good ambulators just did terribly. They did poorly and they stayed poor. But even though we had patients who were, really almost unable to ambulate, a lot of them got better and were ambulatory post-op. So we followed them long term, and the average follow-up was surprisingly longer in the MUST-D group because they lived longer. So we did have some recurrences, but the rate of recurrence at the index level was about the same. The difference was we reoperated on many of those patients. Anybody who had symptomatic recurrence, we just popped the tube back down and suck it out again, and that was it. Or if they popped a symptomatic lesion at a different level, we just go do that level because the outcome from doing that is marginal compared to the massive impact of trying to do 2 separate spine surgeries on a tumor patient. Our 30-day mortality was great, but not statistically significant. Our 1-year mortality was good, but the time until death, everybody did pretty well. Most people lived for about a year, but the MIS MUST-D patients, they lived a whole lot longer. And if you have that option for your patients, I would certainly want it. So here's the Kaplan-Meier curve, and you can see that, when you're out about, 300 days, there is a difference, but it's not a huge difference. But then this actually falls off as we go longer. So one of the other things that we found, and we published on this, is that longevity in metastatic disease is best predicted by whether the cancer has gone to your lungs and how badly it's going on there, as well as your mobility, how well you can walk pre-op. And so we published on this. This is the article that we put out back in 2019 looking at this issue. So ultimately, what we want is patients to be able to walk well, and we want to be able to manage their disease. And so what are the downsides of doing this MIS procedure? There's got to be a downside because right now, what I've been talking about all seems like everything is better for the MIS approach for spine tumor patients. Let me think about that. Yeah. Well, it costs a lot less. So as a society point of view, these numbers speak volumes. The downside, though, really for the surgeons, you generate fewer RVUs doing a smaller procedure. You can still generate a pretty significant number of RVUs, 55 RVUs on this. But if you're an RVU guy, you're looking at this, wait, why? I know my patient's going to do better. They're going to be in the hospital shorter. I'm going to have fewer problems, no complications. But I won't have as many RVUs. Yeah, okay, get over that and then just do more patients because you can do a lot more. You can operate on a lot more people this way than many of the patients were not as sick in the open tumor patients. Then I operated on sicker patients in the must-D group, and they still did very well. So it's a shorter length of stay. So if your hospital is looking at to maximize its billing, they're not going to be happy. The patients are going to be happy. The insurance company is going to be happy. Your taxes will be happy because we're all paying the taxes for Medicaid and Medicare, and we're all paying for, if you're employees or employers, you're still paying for the workers' comp patients. So it would be nice to actually see lower cost to society. Um, Sorry, blood bank, we're going to need less blood and we're going to have fewer transfusions. Oh, wait, that sounds like a good thing too. And fewer complications. So your colleagues in the ICU and your pulmonologists and your hematologists, they're going to have less work. So that's the downside of this procedure. So in conclusion, the must-D technique offers a lower cost, low morbidity, easy to tolerate alternative to doing what I was certainly trained how to do, big spine back wax for spine tumors. It's these reduced complications. Oh, by the way, I forgot to mention that the Cobb angles in these patients did not change at all post-op. If anything, they got slightly better. They got straighter up when we did the cement reconstruction. I suspect that that was more due to the fact that a lot of people just would lock them down instead of trying to correct them. But be that as it may, there's no loss of Cobb angle over time in these MIS patients, and I know that would be one of the things that people would want to look at. Um, so it's, if anything, it's an improvement in the deformity, short hospital stay, rapid mobilization, better improvement for the most affected patients. I mean, this really, it's perfect for the patient who's really already significantly weak. And I think one of the reasons is you can operate on them a whole lot sooner. They require a lot less optimization to get through this operation than you would through a bigger surgery. Oh, and it's shorter, so it's easier to get on the schedule at the last minute. Um, and so, the adjuvant therapy didn't seem to have a significant impact upon wound healing. All of these things really just speak to this should become the new standard of care for spine tumor treatments. So here's an example. This was actually an example we put in our article, and I'll have a link to that article posted up that you can QR code at the end of the talk. But here's a patient with significant intraspinal and extraspinal disease causing severe spinal stenosis, and they already had kyphosis. This is post-op. They've gone from 25 degrees of focal kyphosis down to 19. And that's just by doing this. This is what it looks like in the post-op period. We could see we sucked out a lot of the tumor that was outside the spine, but look what happened to the tumor inside the spine. You can actually see the thecal sac again. So it's not super hard. It does require just a meticulous attention to detail. You do want to make sure that you embolize pre-op, and this is usually embolization of the feeder vessels or of the various vessels coming off the aorta. So in this case, this was one of my favorite patients. This was a delightful gentleman who ran his own restaurant, and he was given at one point 2 weeks to live. He was told, "You have such bad hepatocellular carcinoma. He was jaundiced. He looked terrible. He was dying." But then they stented his common bile duct, and his jaundice went away. And they're like, "Oh, well, maybe you have more than 2 weeks to live. Let's talk about your spine disease." And so we started out with a single lesion, but he was paraparetic. So we did a single lesion. We took the lesion out. He did great. And he went home in 3 days. He didn't even want to go to rehab. We wanted to send him to rehab. And he's like, "I'm fine. I'm walking. I want to go home. I got a restaurant to run." He went back to working in his restaurant. So we operated on him multiple times. Every time he popped up a new tumor, we were able to take him to the OR very quickly, get him in, go home by the end of the weekend, and he'd be back at work on Monday. I mean, he was like the Terminator. You couldn't stop this guy. Um, But after about a year of this, he finally got such severe multifocal disease, not even the must-D could be for him. And so we wound up doing an open lammy, and about a month later, he passed from it, just disseminated tumor throughout his whole body. But he got to spend his last year of his life working, being with family, talking to his friends instead of being in hospice and on rehab, or in a nursing home. So most people, if given the choice, you can walk for the last year of your life or not, they're going to choose walking no matter how many times you operate on them. And so this is actually what he wound up looking like by the end. You see cement all over the place, but you don't see any rods. You don't see any screws. And you can see well what is going on in the canal. And so it's almost became just almost a chronic disease management state rather than a lethal one, except eventually it got to his lungs, and we don't transplant lungs for cancer. So I want to thank you all, and I hope you've developed a few questions for me. I want to thank the organizers of the Virtual Global Spine Conference. This is a great group, and I'm happy to add this talk to the collection of talks that you've accumulated on the YouTube channel. I want to thank my research team, Jack, Cameron, Richard, all of them. And actually, Cameron's been with me for a few years now as my research assistant and scribe. And she's actually first author on this article because she's really put a lot of energy into this. She's done a great job, and I'm so proud of the work she's doing and can't wait to see what she does when she gets to medical school. I want to thank my patients for both allowing me to do this, but also teaching me so much about what I need to learn about what was important to them. And I want to thank you all for listening, and I'm looking forward to any questions you may have on this technique or anything else related to the spine. So for more information, I did promise there'd be QR codes. So the top QR code is for my website if you have questions for me or want to just see more of what we're up to and check out my bibliography on some of the other things that we're doing research on. And the article itself, the lower QR code, is a direct link to the article. We paid to have it open access. So feel free to download it and read on it and give us suggestions. Looking forward to hearing what you have to say. Thank you all.
Thank you so much for that talk. It was super interesting. Having done a fair amount of these with you during residency, I have to say it was such a striking difference between the the patients who got the must-see versus the typical, 3 up, 3 down, laminectomy, corpectomy, cage. There's just no comparison, and these patients did very, very well. And I like your description of kind of, if they do have recurrent disease, it's easy to just drop a tube down and do the same procedure at other levels, as you kind of illustrated in that one patient. Kind of highlighted the benefit of this procedure over the, if you were going to do it this traditional way, it's got to be fused from C2 to pelvis. So,
and who with advanced cancer would agree to that?
Right. Yeah, exactly.
And what surgeon would offer that? I mean, the answer is no one.
Right. My question is, I noticed in your comparison groups, the rate of complication in the open was pretty high. It was almost 50%. Just out of curiosity, what were you considering complications there?
DVT, pneumonia. So and there was I will get to the questions in the chat. Please keep putting them in there and we will get to them. So pretty much anything. And if you look at the spine tumor literature, that number that's not out of whack. I will also say that in the control group, most part, those weren't my patients. So, but we were pretty strict about what was and what wasn't. So any wound complication, any pneumonia, any DVT-PE in the 30 days post-op. So it's not shocking. I mean, these are huge operations. They're on their back, not on their feet. And so they're getting the atelectasis that becomes pneumonia. They're under anesthesia for 7.5 hours on average. So they're more likely to wake up with an aspiration pneumonia or just a general, hypoperfusion issue. They get cold. They get extra blood loss. There's just a lot of reasons why big operations that take a long time aren't the best option for these patients.
Hey Arthur, this is Mike Galgano from UNC. That was absolutely fantastic. I'm very fascinated by the data that you showed. So I do a fair amount of spine oncology here in North Carolina, and I actually started doing essentially an iteration of what you're showing probably about a year or so ago. And I haven't put all my data together yet, but anecdotally, to Rasuli's point, I definitely see that these patients do much better afterwards. I've even developed a different iteration where if they have a bad pathologic fracture, I'll do perc screws on one side, mini open on the other side. The question I have for you is, what if they have very severe bilateral ventral epidural disease? Are you dropping a tube on each side, or do you feel that you're able to reach over ventrally and get maybe 75, 80% of that tumor out? And are you using something like an ultrasound to confirm that you've adequately separated the tumor from the cord?
I would say I've done both. So I've done some bilaterals, and I've also done some reach arounds. Maybe that's more of a lateral extracavitary approach. And then really, once you've got the tube down there, it's really just a question of levering it a little bit more to get an even more crosswise approach. And then I've even done it a couple of times where I'll pop an endoscope down the tube and look around the corner and see, could I see everything that way? That's one thing about I don't like doing these endoscopically primarily, but sometimes an endoscope is a good assistive device just to see what's around the corner. And so, I think you do what you need to do. And I think I didn't in this group have any patients that we had to add any extra supplementation. And so I'm not saying it's wrong to do that. Obviously, one set of perc screws versus bilateral versus, three up, two down. That's a very low amount of radiation impact in terms of what the imaging looks like post-op. So, I think it's nice to have this in your toolbox. I'm not saying that this is the only way to do it, but obviously thinking less is more when it comes to cancer patients. That's the key take home here. And I'm sure you've heard, as I have, not only as platform presentations, but privately from other gray hair possessing spine surgeons. There's no place in spine tumor surgery for minimally invasive approaches. And it's just wrong. It's just wrong. And it's just people who don't do it saying, don't do what I don't do because I can't do it.
So why do you think it's not more popular and spoken about at the podium at these big national meetings? I mean, I'm pretty tied into spinal oncology a fair amount and within organized neurosurgery, and you never really see anyone talk about this. Do you think that there's an element of something less invasive not really being tied to industry? I know it's probably a controversial topic, but do you think that has something to do with it?
I think it definitely has something to do with it. If you're making a fortune off of your industry ties, and I'm proposing a procedure that's going to profoundly reduce the amount that's being spent on these patients, yeah, they're not going to be happy about that. I have no industry connections that are worth mentioning. But that's by choice. And yeah, so I think I think that is a part of it. I don't think it's the only part. I think some of it's just, change is hard. People who don't do something don't want to do it, and they want people to think they are the motive force. They are the thought leader in the field, and it's hard to let go of that. If you're not the leader anymore, not all leaders step aside when it's time.
I've got another technical question for you. So I saw that you placed a screw inside the pathologic fractured vertebrae. What was the what's the intent behind that? Is it more binding for the cement that you've
Yeah,
injected?
it's just an anchor. You pack the cement down and it wraps around the head, so the head acts as an anchor,
I see. Okay.
and it's just to keep it from migrating. And to be honest, most of them I don't think I had to, but there were a few wide ones where I didn't want it to retropulse. So that gave me just a little bit of stickiness until the scar and other things set in, and the patient. We had none of there were no migrations. There were none of the patients, even the ones I didn't use screws on, had any of those problems. But I do think that I think it's a good idea if you have enough vertebral body. And there were even a couple of cases where the whole body itself was gone. I put the screw into the body above, right? We took out the disc and the body, and then I just put one screw into the body above and left it there. In the thoracic spine, it's a relatively immobile part of the spine. They did great. We didn't find that had any negative impact upon their pain, their function, their ability to ambulate, any of those things. So it's just to keep the cement from going anywhere.
Right. And are you doing this in patients that are acutely decompensating? When you get a patient who was ambulatory 48 hours ago and
Right to the
now they've
OR.
come in through the ED, are you taking those patients for this must-D procedure, or are you just doing an open LAMI, a much more aggressive approach? Same
Right
thing?
to the OR. Right to the OR. We pull out the metrics tube, we pull out the PMMA kit. It's actually easier because especially at some of these smaller hospitals, you might have to bring in the hardware. It's going to delay your surgery. This is about as easy as you can get, and it's a shorter operation. I didn't mind doing these at 10 or 11 o'clock at night because I knew I'd be out by 2, not still operating the next morning. When you have if you've had the chance to embolize them, it profoundly reduces your bleeding. And once you've reduced the bleeding in a spine tumor case, it shortens the case. And it's great. You have less bleeding, and then it shortens their anesthesia because you're not chasing a coagulopathy. And then they're not developing transfusion mediated lung reaction in the PACU or in the ICU post-op. I mean, it all feeds into itself. And as you know, the sooner you operate on a patient with a significant neurologic deficit, the better they're going to do.
Well, I love the work you're doing. I'm very fascinated by it, and we should definitely collaborate in the future on this because I'm going to definitely have some of my own data in the future that
I'm
love
looking
to collaborate
forward.
with you.
I'm looking forward to that, and I'd love to get maybe a symposium, built into some of these bigger meetings where we get the MIS section of the spine tumor people, and we kind of bust the glass ceiling of the old guard who are saying there's no old place, and we'll just shout them down. Good. So let's see. Is there any age limit? So Treva T, thank you. There is no actual age limit. To me, it's just more like if they're healthy enough to have general anesthesia, I would do it. I've operated on patients well into their 80s. Would I stop a 90-year-old who was walking and shopping for herself 3 days ago, suddenly got weak? No, I wouldn't. I would offer it to anybody who understands surgery carries risks. Surgery has potential benefit, and the benefits here are awesome. I mean, most patients would be delighted for the chance to not be wheelchair bound for what's left of their life. We may not be able to cure the cancer. That's up to the oncologist. But if we can at least cure their paralysis, they're grateful. Any other questions? Anything else anybody wanted to say or bring up or have me go back over? Certainly, I'm open to anybody who wants to collaborate, talk about doing more of this. I would love to have a randomized, double-blinded, or not double-blind, but I'd love to have a randomized trial going at a couple of major institutions. So if anybody wants to talk to me about that, I'd be happy to give you some insight and help you draft we could draft the proposal. The problem is I don't think any of the big instrumentation companies are going to be signing on. And like Stryker made the PMMA that we used. There are other companies, but and I don't get any money from any of these people, so it's it is what it is. But I do think that this is something we could probably apply for an NIH grant, because if this is saving money, and especially if it's saving Medicare money, Medicaid money, I mean, I don't know why somebody wouldn't fund the clinical trial on this, and I'd be happy to participate in whatever way would be appropriate with anybody who's interested, because I just care how my patients do. You know, I'm not looking at, oh, gee, didn't get enough RVUs this month. I've got to do the bigger operation. You know, when you have grateful patients, I love my happy patients, and I have a lot of very happy tumor patients. And it's hard to say that in this business, but it's great. Anybody else? John, you have any other questions? Jonathan?
No, I think you know, we can end it a little bit early. It's, you know, this was a fantastic and a very, very interesting talk, Art. I really appreciate you coming tonight. You know, we'd love to have you back. I know there's many, many, there's a list of many, many Jenkins talks that we can give.
Yeah, well, I'm certainly happy to jump in anytime. And if anybody wants to download the article, as I said, we put it out there for free, so you can have at it and pick it apart and tell us what you think. And good luck. Let us know and go out, be awesome.
Thank you so much. Thank you so much, everybody, for joining us for this next Virtual Global Spine. Hope you have a great night and a great rest of your week.
Bye, everyone.